lectures, so we'll see what time we finish up for today. So the good news about the AMSET, so in psychiatry, we really don't do a whole lot of physical exam stuff. We tend to look more at how the patient is presented from a mental aspect. So the mental status exam is what we use in place of the physical exam, right? We're still looking at skin, we're still listening to heart and lungs, but that kind of takes a backseat because we're more concerned about why they're depressed, why they're sad. And what I'm going to teach you guys today is kind of essentially how to professionally judge somebody, right? And you guys already do this anytime you meet somebody new. So anytime somebody walks into the room, whether it's here, whether it's home, it's the first time you meet somebody, you're automatically judging them and coming to a conclusion. So now I'm just teaching you how to take that to the next level. So you guys are going to become professional judges. It's great, right? Then you guys can do it at a party and really get into it and start analyzing people. So real quick, this is probably going to be your guys' second kind of actual medical class. Your first one was probably HEENT. And HEENT is kind of like this weird conglomeration of like eyes, so ophthalmology came in, or maybe optometry, then you had like ear, nose, and throat. This is your first like actual medical subspecialty, right? So the questions are going to be a little bit, not necessarily harder, but they're going to be longer. You guys are going to start getting more scenario-based, or you're actually going to get a full description of what's going on. It's going to be a lot less of that very first order, what is depression, and then define it, right? It's a lot less of that. It's going to be, I'm going to give you a scenario, so you need to be able to kind of read the skim, figure out the question that I'm asking, and then look at the answers and select the best option, right? So hopefully you guys are already starting to see that, and now you just kind of need to keep going with that, especially as you get ready to go into your junior and your senior year, where it's going to be a lot more patient scenario-based, a lot more second and third order type questions. So this is block one. These are all the lectures that we're going to cover. We'll go over the meds again, but we're going to spend a lot less time focusing on like mechanism of action, a lot more time kind of focusing on what disorders go with which med and kind of how to appropriately use them. But really that pharmacology lecture was your ground level for the psych meds. So block two, this is what we'll talk about after you guys' first test. You can kind of see the breakdown. We don't really go into a lot of like the psychotherapy aspect of it in this course because that's not really what you guys as primary care are going to be doing. So we'll kind of talk briefly here and there about some of the different therapies like CBT, motivational interviewing, psychodynamic therapy, but that's kind of above y'all's level and I wouldn't expect you all to know that. You'll need to know the basics of when to refer, which one to select, but that's kind of the level we're talking about with that. Sources, so these are your two primary sources. You have your DSM-5, which has its own issues, and then you have current. The DSM-5 TR, if you actually read through what that book is supposed to be, it's actually only supposed to be used by people who are already trained in psychiatry, because all it is a whole bunch of criteria for diagnoses that you have to click in order to diagnose somebody, right? It's a billing and coding tool, and it's also used in rule of law when you're looking at forensic psychiatry cases, right? It's not really supposed to be a teaching tool, but it's kind of been turned into that by the academic community, so it kind of has some issues with it. Next, Current. Current's a pretty good resource. It's very kind of bare bones when it comes to psych, but from a primary care aspect, it's a pretty good resource, and we'll kind of use both of those as well. You guys should be able to get those from Stimson Library. You'll be able to log on and get there. You just have to go now the super roundabout way to get in there. It's not as clear cut anymore. So if you guys don't have those accounts, make sure you set them up if you want access to the books, right? So psychiatry as a whole, the profession, again, if you look kind of when it originally started, first kind of came out around the 1800s, but mental health conditions have been with us since essentially the dawn of time, right? Ever since human beings have started to walk the earth, we've had mental health disorders with us. And that's where sometimes there's a little bit of a stigma associated with mental health because it is your just normal human emotions that you have. Like everybody's been sad, everybody's been happy. I'm sure you guys here are anxious, right? Very much all the time now when you're taking about tests. Those are normal human emotions, and we have to be careful that we're not pathologizing a normal response. right? It's when those emotions start to become the dominant focus of that person's life, it starts to overwhelm them, and now interferes with other aspects of his life that turns into a psychiatric disorder, right? With a few exceptions, when you're talking about things like schizophrenia, that is a true psychiatric emergency case that has to be addressed, and that is not a normal human condition, right? Bipolar disorder, we're talking about mania, that's a true psychiatric emergency. It's not a normal state. We've all been super happy, but when that happy state stays forever, that's where it becomes a problem, right? So introduction, anytime you're talking with a patient, don't forget your guys' specialty, your primary care first. So anytime you always want to rule out organic etiology. You're going to hear me say that a couple times. When the tests come up, I'll throw you a scenario, and it's going to sound like a psych case, and you're going to be like, wait, why is he asking about hypothyroidism? It's because I want to make sure you know, rule out organic etiology first. Once that's ruled out, then you go down the psych realm, right? When you guys are in the other classes, you'll see when they come up with that differential list, psych is always at the very bottom. It's in every single case, but everything else has to be ruled out first before we go to the psych realm, right? Then, when I'm talking with my patients, we always want to take patient choice into account. That's really how we get buy-in. If I tell the patient to take their Zoloft, it doesn't make a difference. But if I can get them to agree and then recognize the benefits and the risks of their Zoloft, now also that compliance starts to go up. So anytime we're talking about meds, we're always going to talk about the indications, the risks, the benefits, the alternatives. And when you guys are documenting in your note, you can literally just put that in abbreviations, IBRA, saying you discuss that with the patient, right? You always want to make them aware of all of the risks and benefits. The worst thing you can do is give a young man some of his Prozac, not tell him that he's going to get ED, and now all of a sudden he has ED and you think that you ruined his sex life, right? Always educate your patients on everything that's going on with them. Right? I don't feel like I need to justify my profession, but I guess you can say that, right? So again, psych is a huge issue and it's actually increasing. So we're getting a huge surge in psych cases, especially after COVID. It hasn't really come down. And on the flip side of that is the number of psychiatrists, psychologists, they're actually starting to decrease because they're all hitting retirement age. So we're getting a lot of people leaving the profession at the exact same time. So there's a huge need that we don't have the resources to fill, and that's where primary care comes in. A lot of times, primary care is the first ones to see a patient, first ones to prescribe a medication. You can kind of be that very first step and try and get some improvement, and then if not better, refer back to us. Yes?
So with psych cases going up, do you think that's a case of more people getting diagnosed than were previously, or is it just more overall?
So I think it's kind of nothing in psych is ever clear. It's a yes, but also asterisks, right? So I think, one, the stigma surrounding behavioral health is starting to decrease to where now it's acceptable to go get care, right? So I think that's one. Two, I think it's also, we as a society have come to the conclusion that if I'm weird or different or sad, there must be something wrong with me. And now I need that label. Kind of like if you ever watched TikTok, when you're like, oh, do you have difficulty focusing? Do you have difficulty paying attention? Are you super happy and you have difficulty concentrating? Well, obviously you have ADHD, right? So now you're kind of seeing that in TikTok popping up where it's like, oh no, you have this disorder, and they go to us to get that diagnosis. So that's another one. And then again, we're also kind of having that decrease in their profession, so now there's more need for it, right? So it's kind of a weird mix of all of them. Cool. That answer your question?
Yes, sir.
Cool. Good. All right. Cool. So this is just kind of a idea of how the DSM-5 is laid out. So each DSM-5, what comes with it is a giant pink box, right? There's a whole book. It's super thick. I'll have to bring mine in at break time. It's a super thick book, but at the beginning of each condition, there's a pink box which highlights all the diagnostic criteria. It's going to look like that, right? And what it tells you is that all this criteria has to be met in order to make a diagnosis, right? And it lays it out verbatim what you guys need to have. And when we're going through our lectures, we're talking about like depression, anxiety, we'll actually have that pink box for each one of the conditions. When you guys are studying, that's the big thing to know. That'll get you to like an 80% solution is knowing the diagnostic criteria for the conditions. And then we'll kind of go into the meds, how you treat it, different risk factors and stuff like that will make up kind of like that last 20% of the tests and things. So again, make sure you guys rule out organic etiology first, right? And then our cutoff that we're going to use in the class for pediatrics versus adult is going to be 18 years of age, right? It's a lot more nuanced than that, especially when you're talking about society nowadays, like when it is an adult. Legally speaking, 18, so that's what we're going to use. Just realize it's not as clear cut when you're actually out there in the world talking with patients, right? I've met many a 25-year-old who acts like a teenager, and you're like, dude, you gotta learn to adult, right? So in the back of each DSM-5, there's actually a differential diagnosis, so it gives you other options that you can read. A lot of times they're going to be psych cases. Again, it's nice that it's in the DSM-5, not super relevant right now. Good. So this is from the syllabus. I haven't gone in and updated the syllabus yet, so it's still the older one that's in there, but it's still relevant, it's still applicable to the class. I'm not making major changes to the syllabus. It's more just that administrative updating name, title, things like that, okay? So, all right, let's get into the psychiatric interview. Before we get into that, any questions that kind of about the course structure, expectations, anything like that at all? This also allows me to take a sip of coffee. All right. So there's your references. Psychiatric interview, that's from the syllabus, that's your expected learning outcome. So at the end of this course, you should be able to do all of these things. All right, so the AMSAT. It's kind of the best acronym we have is appearance, mood, sensorium, intellectual dysfunction, and thought. So if you can kind of keep that in mind, that's your acronym that you're going to use when you're breaking down what things you're asking for each category. And we're going to go into them here in just a second, right? Orange circle, so just a real quick, if you guys see the orange circle on the slide, because I do actually want to try and make you guys better clinicians. I know your goal is to pass the test. My goal is to make you guys good clinicians. So I've included some extra stuff that I'm not going to test you on, right? So you don't need to waste your time looking at this, but just realize that when you're talking about actual patient encounters, this stuff actually starts to matter a lot. So the case formulation is something we use in psychiatry. We don't necessarily use an assessment and plan section. So it's a little bit different. You'll see that when you're reading your notes. But we're going to use that kind of biopsychosocial assessment when we're evaluating our patients before we kind of make that diagnosis, right? And I'll kind of give you guys a great example of it. Has anybody here ever been like a drill sergeant or drill school, AIT, anything like that at all? No? Okay. So has anybody dealt with a new graduate that just came to your unit straight out of AIT basic, right? So do they fit in perfectly every single time? Not really. A lot of times there's that struggle adjusting to military culture, adjusting to how a unit's done, adjusting to the expectations. Like you just can't just go off and leave anymore. Like accountability is a big issue for the military, right? You can't drink whenever you want, right? We can't be drunk on duty. UCMJ takes effect, right? Sometimes our soldiers, sailors, airmen, they have a hard time adjusting to military life. And what that's called is an actual diagnosis, adjustment disorder, right? Makes sense. Do you think any amount, if they have a hard time struggling with the military, is any amount of medication, any amount of therapy going to make that difference and actually fix them? Not really, right? They're either going to adopt the culture and adjust and they will assimilate, or they won't, in which case the fix is they need to leave the military. That's where you kind of get into that social aspect, right? I can't change that you're in the military right now, and that's your primary stressor, so you need to take that into account, right? If you're dealing with married couples and they're going through divorce, divorce is super nasty a lot of the times. Like you want to talk about two people trying to fight each other, divorce can be rough, and that can be your primary trigger. Now all of a sudden you're feeling sad, depressed, anxious, mad, all at the same time. Those normal human emotions. No amount of medication I'm going to give you is going to fix those symptoms until the divorce is over, right? So again, we have that social stressor. Genetics, biologic plays a portion, right? So when you're talking about alcohol, family alcoholism runs in families, right? There's a very strong genetic component. If your dad, brother, sister is an alcoholic, your risk is 4 or 5 times greater than the general population. That's non-modifiable, something to take into account, right? When you're talking about medications, so remember we talked about cytochrome P450? Sometimes people are super metabolizers, sometimes they're not. That's a biologic factor, so maybe my meds aren't working as well because they're just burning through the medication. I have to go up on a higher dose. So anytime we're talking about a psych patient, we're always going to use that biologic, psychologic, and that social, right? For psychologic, kind of it goes back to that joke, like, well, tell me about your childhood. There's a lot of truth to that, right? So if you had a very rough childhood and you were in a home where there was abuse going on, that's a psychological development. It takes an effect on you as you're developing, right? It's adverse childhood events. The more adverse childhood events that you have, the more likely you are, the more at risk you are for developing a psychiatric disorder as you grow older. Whether that be conduct disorder, antisocial personality disorder, this all goes into effect. So when you're doing your interview, talking with the patient, getting that HPI, gathering all that information, it gives you a clear idea of what's going on with the patient and what's going to work best for them, right? This is the chart just breaking it down. Again, you guys don't need to know this, but when we're talking about a patient from a psychiatric perspective, we're taking into account all of these different things that's on that chart when we're kind of coming up with our treatment plan, right? So, biggest thing I'll tell you guys is, if you're dealing with a psych patient, you're going to hear all sorts of different stories. Take the patient at face value. They're your patient. You're there to take care of them, right? If they're a male and they're divorcing their wife, right, and they cheated on her with another person because they were the love of their life, don't be judging, right? It's not your job to get involved in that relationship, right? You're there to take care of the person who's in front of you. You say, Roger, hey, I understand. Sounds like that was a tough scenario to be in, and then you move on, right? Don't get judgy with people. And again, foot stomp, right? Rule out organic etiology first. Make sure that it's not being better explained by like a substance use, right? Make sure it's not being explained by like a thyroid disorder. Make sure it's not being explained by lack of sleep, like an insomnia or something along those lines. You're still going to do your OPQST, your sample. Those are great. Again, that's just grabbing that basic information. You need to grab that demographic information, married, divorced, single, number of kids. That doesn't go away. They're going to grab all that information for every single patient you have to see from now until the time you stop being a PA, unless, of course, you're in an emergency scenario, in which case that changes a little bit. The one thing I would say with psychiatric cases that is unique is collateral information can be a huge resource when you're trying to make an accurate diagnosis on a patient. So collateral information is, you tell me you're super sad and you're sleepy, then I'm going to ask for permission, like, hey, is it okay if I call your wife? And I'm going to call her, like, hey, would you mind kind of filling in some blanks for me? And that can give you an idea of how that patient's acting overall, right? When over at 16, over at BAMC, we get a lot of the basic trainees, and that's a big thing that we do is we have to call back to the families and figure out what was going on with them before they ever showed up to basic training, right? You just have to be careful with it because that does start to infringe on HIPAA, and there's a safe way to do that. But don't ever be afraid to get collateral, especially if you're worried about like an ADHD diagnosis or something. Right? So real quick kind of definitions of mood versus affect, just because it can get a little bit confusing. The easiest way I've kind of thought of to break this down is mood is something the patient tells me. The patient's going to tell me that they're sad, happy, anxious, mad, frustrated, right? Whereas if I'm talking about affect, that is what I notice about the patient, right? And we, again, this is something we do naturally. Anytime you see somebody, you're already deciding, well, do they look engaged? Do they look bored? Do they look anxious? Are they pacing around the room? Are they hot and sweaty? It is your assessment of what their affect is. Like, you can tell when somebody's angry. You can tell when somebody's frustrated. Now you're just putting that into a note, right? And then what you want to do is you want to make sure that that affect and that mood are matching up, right? So if somebody is just sitting here in their chair, falling asleep, and I'm like, hey, are you engaged? Yeah, I'm engaged. Okay, well, that's not really matching up with their affect, right? Because they're falling asleep in their chair. If somebody's sitting in their chair in the office clinic looking at you, they go, you know, I'm just super frustrated with what's going on. They're like, it doesn't really match up with how you're presenting. You're looking deadpan face, you're texting on your phone, laughing into the clinic room. Like, this is not matching up, right? So, Am said again, so appearance, mood, sensorium, intelligence, thoughts. Under appearance, we're also looking at behavior and speech. And under sensorium, we're looking at, this is the one you guys all talk about at A&O times 3, right? That's your orientation, memory, concentration. thoughts, there's a lot going into that with judgment, coherent, is it logical? That's all going under thoughts, right? This is from your current textbook. I went in and pulled it yesterday. It's a good breakdown. It kind of breaks down the different categories and what we're looking at. It's okay. It's a pretty decent chart. There's some other stuff we're going to add to it, but it's a good starting point, right? This one, this is a good chart. I would almost say if you want to keep this up as we're going through, it's a good one-stop shop for the AMSET and everything that we're going to talk about. But again, I'm not going to tell you to memorize this chart. I will ask you questions like I'll give you a presentation and ask, okay, what category does this fall under? Is it appearance? Is it mood? Is it sensorium? But I'm not going to expect you to do an AMSET on a patient scenario, right? It's a little bit above this level. It's hard to do on paper. So this is just a whole bunch of medical terminology. Again, I'm not going to test you on medical terminology. I'm not going to ask a question of what is the definition of echolalia? That is kind of below this class level. Again, you guys are expected to have a med term class before you come here. But I understand that sometimes we take the online version and it's not that great. And also psych, we use some words that maybe aren't in the regular vernacular. So if you need a quick definition of some of the stuff that's showing up on here, especially when you're talking down here, I just kind of threw it all in there for you guys. That way you have it if you need a quick reference back to what we're talking about. Okay. There's that one. There's that one as well. All right, so appearance. Grab a coffee real quick. My throat's bugging me. All right, so when you're talking about appearance, again, this is that very first impression. All of you guys already do this when somebody walks into a room, right? Anytime your new instructor comes in, you're automatically analyzing them. You want to see how they're dressed. Is their hair within regulations? Do they look appropriate? Do they seem mad, happy, sad? Do I think this is going to be a good instructor or a bad instructor? Do they seem egotistical? Do they seem like they're not confident? Trust me, we read your guys' end of course evals. You guys get super judgmental sometimes in those. Because again, you're already judging people. Now we're just putting words to it. So now, when you guys do your end of course evals, I really want to see this verbiage in there, right? I really want you guys to get into it. I would love it if someone actually gave a full AMSET of me at the end of the course eval. Anyways, I digress. And kind of when you're thinking about this, right? When you're talking about a patient and their appearance, I'll give you guys some good examples. In San Antonio, it's like 100 degrees outside during the summer, right? And if you have your patient, they come into your clinic in San Antonio and they're in a full-on winter's jacket, right? And they're long pants, gloves on. That's weird. That's not adding up to the environment that they're in, right? That's different. Their appearance is off, right? Do they appear their stated age? And for you guys who have been to like NTC, JRTC, or any sort of like long field training, when you've done 30 days in the box and you haven't been able to shower really in 30 days, you haven't been able to like properly shave, you haven't been able to get your hair cut, when you come out of the box and you look at yourself in the mirror, you're like, oh, holy crap, who is that person, right? Living on the streets takes a toll on you. Having a mental disorder where you're not going outside, you're not exercising, you're using drugs, and you're like not engaging people, it takes a toll on the body. So do they appear their stated age? If that chart is saying that they're 30 years old, you open the door and you're like, holy crap, this guy looks 60. That's something that's wrong, right? Like what's going on with them? There's a mismatch in their appearance, okay? And if they're worried about like an OCD and you walk in and they're very kempt, buttoned down, everything's perfectly aligned, everything's very fastidious, very neat. Again, that could be a sign most of us, we have a little bit of slop built into our lives. We're busy people. That could be a sign that maybe it's like an obsessive compulsive disorder. Maybe it's a personality disorder where they're very grandiose, right? Psychomotor activity. So if you guys are thinking somebody along the lines of like a mania, that person will not sit still. They'll be up, moving around, jumping, very animated, right? That's psychomotor activity. So again, you're like, this is not a normal person. Most of us can sit still in our chairs, right? It's not matching up. Something's going on with them, okay? This is also where you want to do that quick check to make sure that you're not next to something that might be nasty. So doing that quick look to make sure that stuff's not jumping out of their hair, which could be lice, right? Making sure that they're not having a lot of stuff between the webbing of their skins, webbing of their arms, like that, which could be like scabies. Because again, living on the streets, maybe you're not taking care of yourself, maybe you're not having access to a home or good hygiene, you're not taking care, stuff starts to grow on you, which shouldn't normally be there. So do those quick checks. because last thing you want to do is get lice. It's gross, right? So evidence of emotion, how are they presenting in there? If they're telling me that they're going through the worst day of their life and they're divorced and their kids are getting taken away from them, but they're not tearing up, they're not crying, like, again, that's a pretty emotional event, but there's like a mismatch a little bit going on. There might be something underneath, right? They're not displaying emotion. Most of us can display emotion. Maybe it's a very flat affect where you're looking at him and you're like, man, are the lights on? Is anyone home in this guy? A very flat affect is almost a sign of schizophrenia, right? Where there's really nothing going on. They're not showing their emotions, okay? Next, you're talking about their body language. So again, how a person presents ourselves, we pick up on these little micro expressions. We just naturally do that as human beings. If you talk about evolution, if you go down that route, it's how we know it's our survival instincts, right? So when somebody's not part of our tribe, they're different. Are they hostile to me? Your body's been trained to pick up on those, so it knows when it's in danger, when it needs to activate those fight or flights, right? So now you're automatically using those. We're just putting some words to it, right? Stereotypia, so that's like a repetitive motion. So a good example is autism. So autism disorder, it's classically called hand flapping. So in a kid who's very agitated, if they have autism, they can start flapping their arm, and it's just a way to kind of get that anxiety or anger out, right? Something to look at. Lastly, flexibility, that's part of cataplexy. It's actually super interesting. So essentially, if I take your arm and I put it in position, somebody with cataplexy, they'll sit there like that, and they won't ever move it. It's super interesting to watch. Super boring to talk to a cataplexy patient, but super interesting, right? Echopraxia, so that's just coughing and movement or gesture. So I'll give you guys a great example of this one. So have you guys ever been walking down the street and somebody waves at you like this, and then you immediately go like that, and you have no idea who that person is? You're just mimicking that behavior instinctually. That's echopraxia, right? And then tics, repetitive acts, those are pretty straightforward. So I was taking care of a young girl in the ER, and I kid you not, every 10 seconds, she'd rub the bridge of her nose and then rub her hand. And she did this for the entire hour interview. She had a constant tic that was going. So again, to the point where she was actually having abrasions on her face from how often she was doing it, right? So that's a tic or repetitive act. Attention. So this is if you're trying to talk with somebody and they are just not looking at you, like bouncing around the room, thinking things like ADHD, or the reverse of that, if they're just super self-absorbed. Yes? Is that a question?
Between stereotyping and the last one, the tick, how do you distinguish which behavior?
Yeah, great question. So a tic is almost involuntary. The patient really has no control over it. They're just doing it, right? Whereas with stereotypia, they actually have some control and they can stop themselves. So if you're like sitting in your chair doing your lecture and you're just rocking back and forth, right, and then you notice it and you stop, you have control. That's stereotypia. If you can't control and you almost have an urge to do it, that's where it becomes a tic, right? Think Tourette syndrome, right? Where you just have this involuntary movement. That's what we're talking about with the tic, okay? Great question. Did I answer it? Okay, cool. Good. So attention, either distractibility, self-absorbed. Self-absorbed is where that person is just really into themselves. You don't see that as much. You start to see that when you're talking about like a personality disorder. When you're talking about, hold on, drawing a blank on it right now. I'll come to you in a second. Okay. And then speech and language, right? So this is just analyzing how a person talks, right? So is that so I'll give you guys kind of a great example where this can kind of turn into a biases, right? So if you're talking with somebody and they're just super slow to respond, like, hey, how's your day? Well, my day was good, right? Very slow response. Now all of a sudden you start to think, man, is this guy all the way with it? Is this guy dumb? Is he not educated? And you're jumping to that conclusion just based on their speech pattern, right? Whereas, now if I'm talking with somebody and you're like, ask me a question, I'm like, oh man, my day was great. Like I went fishing, and then I went out to the park, and I played with my kids, and then I went home and my truck broke down. I was trying to fix my truck, and the battery went bad, and I was replacing the battery, and I had to go all the way to Napa. That's like a really rapid, pressured speech. You're like, holy crap, is this guy on drugs, right? And again, you're making that assessment based just on their speech pattern. So whether you know it or not, you're taking that into account, okay? A loudness, so soft talker versus spontaneity. We've all encountered that where somebody's in the corner, maybe they're shy, anxious. They're like, hey, I just had a question. You're like, I can't hear you. I have no idea what you're saying. You gotta speak up. So that's like somebody who's having a soft talk, right? Articulation, so word salad, that's where they give you a whole string of words and it makes no sense, right? So you're asking like, hey, what's your name? Potato, in microwave, fast, snow. And you're like, okay, that makes no sense. That's a word salad. We tend to see that in things along the lines of like strokes or dementias, anything that's going on with that brain pattern, that's word salad, right? Echolalia, that's where I ask you. And then, again, great example, we've all done this. We're like, hey, how was your day? My day was good. How was your day, right? You just instinctively do that. You're just echoing back the last thing that was said to you. That's echolalia. So neologisms, and regeneration, that's kind of very similar. So essentially what it is you're just making up a new phrase and then giving it meaning even though society as itself has not given that meaning, right? My kids, I still have no idea what this means, but they just randomly go in the house and they start yelling 6-7. Like 6-7. I don't know what it means. Like, yes.
It doesn't mean anything.
Yeah, so there you go. So that is a neologism, right? So again, it's just something that was created that has no real meaning. Very similar to reverberation, where you're just spouting something off, where it might have meaning to the patient, but to you, it has zero meaning, right? There we go, to the youth of tomorrow. So there is, hold on. So there's your verb. So this is why I always write everything down, because sometimes they get switched around. So there's your verb generation, right? And then one back. There's our neologism. So new coin, so again, 6-7, think neologism, right? Verb regeneration, so that's just the person just randomly says something, has no real meaning, but maybe it has meaning to them, right? I don't have a good example yet of that one. I'll have to think of something and come back with it. Okay. Where was I at? Okay, mood affect. We've kind of already talked about this. The biggest thing when you're talking about mood and affect is you want to make sure that they're congruent. Are they the same? Are they matching, right? And then don't get mixed up. Mood, the patient is telling me. Affect, I'm making that assessment of the patient. Right? So sensorium, this is the one that you guys all love to go to. Everybody knows sensorium. Are they alert, oriented to person, place, and time, and event, right? You guys nail that, hands down, every single time. But just realize there's a lot more that goes on when you're talking about a sensorium, right? So somebody can be alert, oriented, and engaging with you, and then you're talking with them, and you're like, this person is completely batshit crazy. They have no idea what's going on, right? I kid you not, like I'll probably talk about this patient a couple times. I had a patient who was manic bipolar. They were a dentist, believe it or not. So a manic dentist. It was great. Like this person was super with it. They didn't even know something was really wrong with this patient for about a week or so. Because like she was still doing the job, she was doing her exams, like she was turning out products that the people were asking for. But then when you're talking with her, you're like, oh, this girl's with it. But then she's like, hey, I need to leave. And you're like, well, why do you need to leave? I need to go donate a kidney to my dad. And I'm like, okay, this is reasonable. I can follow along. It's making sense. And she goes, but don't worry, I can regrow kidneys. And you're like, okay, hold on. Now we lost it. That's not making sense. So again, they're very alert. They're very oriented. But as you're talking to them, now you start to see the cracks that come through. There's something going on. The brain is misfiring, right? So memory, remote. Everybody loves to ask, like, who's the president? That's good unless you're not in the United States or you're dealing with maybe a family that's immigrated recently. Believe it or not, the United States is not the center of the world. I know, I disagree, I think it is. But there's other places out there, right? So maybe who's the president is not necessarily the best assessment, right? So you're trying to get something that's remote. So you might ask like, hey, do you know what city you're in right now? Do you know what this building is called, right? There's other ways to kind of assess that memory. And then kind of that recent memory, that's where you can kind of give them a list of like, hey, at the very beginning of this encounter, I'm going to tell you some fruits, so apple, banana, orange. And then later on, maybe 5 or 6 minutes down the road, hey, do you remember those 3 fruits I asked you about? If they're able to recite them to you, then you can know recent memory is intact. So you always want to check their remote memory and their recent memory, but make sure that they're relevant, right? Concentrating or calculating ability. Anytime you guys are on the inpatient setting, and actually you should be doing this with somebody who's had like a TBI or any sort of brain injury, you want to check somebody's calculating ability, right? Because again, somebody can be super with it, know what's going on, but their ability to concentrate and calculate is now affected. Has anybody ever worked with like a patient with dementia or Parkinson's and stuff like that? No? Yeah. Have you ever asked them to draw a clock face? No? It's super interesting. If you're talking about like Alzheimer's disease, Parkinson's disease, a lot of these dementias, if you ask them to draw a clock face, they won't be able to. It'll actually come out super wonky and weird, and that's one of the ways we can kind of start to clue in on a diagnosis, right? If you ever want to like Google something in your spare time when you're bored, like clock face is associated with dementia. It's super interesting, right? So this is where you're just checking that quick ability. It's like that serial counting. So count up by sevens for me. 7, 14, 21, 28, right? You don't have to make them go all the way to 100. We're just wanting to make sure that they can calculate relatively quickly, right? You can ask them to spell a word backwards, so the common one being spell world for me backwards. And then they can do that. They're able to concentrate, they're able to calculate. Has anybody ever done the MACE exam? Right? So that's why that's part of that MACE exam. You're checking if that brain is injured. Now if that's affected, there's an issue going on with the brain, right? So intelligence and cognition, this is where it kind of gets a little bit subjective in this area. You're basically trying to make an assessment of this person's education level. Are they with it or are they not, right? This is where you need to know if you can get that collateral info. So if you know that this person's attended college, they have a bachelor's degree, a master's degree, so they're relatively educated, and you're talking with them about topics like, hey, so tell me about a car. How does a car go? And they go, well, a car is fueled by magic. Right? Okay, not making sense as an educated person, right? You can always start with very simple concepts like, hey, where does the sun go when it goes down? And you kind of increase complexity, and then you're doing your best to make an assessment about their intelligence level, either above average, average, or below average, okay? Again, if you're thinking about dementias, delirium, so things like Alzheimer's. Alzheimer's is a super bad disease because it's slow, it's progressive, and essentially you take somebody who had a high function level and you slowly decrease them over time to basically a state of childhood. So that lifetime experience slowly whittles away in Alzheimer's disease. It's very upsetting to the families, right? That's where that intelligence level comes in. So thought, this is kind of like one of your bigger categories. All of this goes under thought process. Some of it's pretty straightforward, like coherence. Are they able to keep a sentence together, and am I able to follow along with what they're saying, right? That's coherence. And again, you guys are all experienced with that because as instructors, we're trying to teach you, and sometimes we say things and you're like, okay, that makes no sense. This guy is incoherent, right? So you're already making that assessment. Is it logical? So does it make sense? So again, thinking back to that bipolar patient, she was coherent. Her thought process was logical up until the point she can tell you she can start regrowing organs, right? That's where now that logic train has fallen off. Goal directedness, do they have something in mind and can they follow along with that plan, right? Things with like schizophrenia, they tend to lose their goal direction. They have no motivation. They don't really go and do things anymore. That's their goal direction, okay? So coherence, we've already talked about that. I gave you guys some examples. I made a misspelling right there. You can fix that, right? Logical versus illogical, and then your goal directedness. This is that tangential versus circumstantial. So do you guys remember back to that video I played you in med history all that long ago? The guy on the streets who interviews with the camera, right? So when he's giving his speech, it takes about a minute for him to come back and answer the question of what is his name, right? He still answers it, but it takes time. That is circumstantial, right? If he never comes back and answers it, and the questions just stem off of each other going down, 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 that is tangential. That's how you can separate those two apart. Associations, so loose, flight of ideas. This is kind of seen with that mania where they just have so many ideas popping in their head all the time, and they're just spouting them out, right? They can't control them. Whereas blocking, that's where you're talking with somebody, and then they just stop. right? And that they're trying to think something through, that's blocking. They may jump back in and give you an answer, or they may not, right? They may jump onto a completely different topic. That's blocking. Okay, oh, sorry, I mixed up. Line of ideas is down here, sorry. Loose thought, that's shifting from one topic to another. My bad, sorry. All right, so perceptions, there's a great slide that comes up here in just a second that kind of breaks these down versus perceptions versus delusions versus illusions. Again, we tend to see that in psychotic disorders, you tend to see that in mania a little bit. Those are where you're seeing those. So that's a pretty good, that's probably the easiest way I've seen. It's a really good slide talking about the differences between hallucinations, illusions, and a delusion, right? Because there is a very difference between them. It's all about how your body is interpreting the world around them. It's kind of giving those misconceptions based on what's going on with them, okay? Other content, so this is like the catch-all. So this is where you're always going to ask, like, hey, are you having thoughts about harming yourself or harming another person? Do you have a plan on how you would harm yourself or how you would harm another person, right? You always want to ask that. Poverty of thought, this is where, like, I ask you a question, like, hey, so what do you think about your depression? Like, what do you want to do about it? And they just are like, well, it's bad. Like, that's poverty of thought. It's very concrete thinking. Most people were able to kind of articulate and talk through what's going on with it. If you're not having that, it's called poverty of thought, right? And then noteworthy memories. This is if they have something that's kind of like stuck in their mind and coming out, you can include that. It's kind of the catch-all category, right? So judgment, appropriate decision making in real life. So this is kind of where you're making that assessment of, and I see this quite a bit. So somebody will have a significant suicide attempt, right? Whether that be they take an entire bottle of Tylenol, they go to the ER, we now have put the NAT on Tylenol, we're not worried about an overdose anymore, and they go, yeah, I'm just ready to go home. And you're like, you just tried to kill yourself, and now you're saying you can go home in the exact same environment. They're not showing good judgment, right? They're not necessarily recognizing the situation that they're in, right? This is a patient I legitimately had. This is super interesting. So she was homeless, got hit by a bus, not homeless, she actually had an apartment. Got hit by a bus here in San Antonio, completely shattered her arm. We got called to do an eval on her because she was wanting to leave the hospital. And as we're talking with her, she had like orthopedic surgery with a flap created, and she had metal put in place. Like, she needed to be in the hospital for about another week or so. And then talking with her, we're like, well, how do you think you're going to be able to control like your wound care? How are you going to do pain control? She goes, yeah, don't worry, I can buy hydrogen peroxide over the counter, and don't worry, I got a guy who can get me heroin for pain control. Like, hey, I love that you have a plan. That's awesome. But you're not really showing you the inside of good judgment into what's going on with you right now, right? Another way you can ask this if you don't have that is kind of, does it conform to society standards? Which again, that's very subjective, very squishy. A great example is a letter, right? So if you're at a mailbox, you see a letter on the ground that's stamped, it's ready to go, somebody probably just dropped it, right? The average person in society is going to pick that up, just drop it in the mail stop, right? That's good judgment. Society, we can kind of agree that that's appropriate, okay? Where it starts to get impeded is, oh, I'm going to open up the letter and just see what's inside, right? Again, we don't really want privacy being invaded. We don't poke around other people's business. That's, as a society, we kind of come to that conclusion. So now you can kind of say, well, their judgment's a little bit impaired, right? Or if they say, well, I'm going to take that letter, I'm going to burn it. Like, okay, that's not normal behavior. Like, we need to talk about what's going on, right? So again, that's where, like, it's not a perfect example. That's where it starts to get very subjective. But that's when you're making that judgment, that assessment, right? Abstracting ability. So this, the classic one you're going to see is like a proverb or proverb interpretation. So you're going to like tell them like the tortoise and the hare story, right? What's the moral of tortoise and the hare? Well, if you just keep working and plodding along, you'll win. Like, or it's a proverb like two in the hand, one in the bush, right? The downside to that, to a proverb interpretation, is that it's very, very, very subjective, and depending on how that person was raised, the environment that they were in, the culture they come from, they may come to a completely different conclusion, right? So it's okay, it's something you can use, but they're not perfect. What I prefer to use is I actually use comparisons. This tends to be a little bit easier and better to understand, right? Because if I ask everyone, hey, what's the difference between a king and a president? most of us are gonna be able to say, well, a president is elected and a king is for life, right? They're able to do those comparisons. What's the difference between a shrub and a tree? Trees get really tall and branchy, shrubs are super short. Like those comparisons, they make sense. If they start going off on the crazy train, now all of a sudden they're not gonna be able to make those comparisons, or the comparisons don't start to make sense. So I tend to use these ones a little bit more, which is that comparison, right? And similarities and differences. I like that more than the Proverbs. All right, and then lastly, insight. So does the patient understand what's going on with it, right? And that kind of gave you a couple examples. The person who thinks they can regrow kidneys, they're not showing insight into the scenario, right? If a patient just tried to commit suicide, and now they're requesting to go home and it's only been like an hour, again, they're not showing good insight into their scenario, okay? If the person thinks that they can do their own pain control and they can just clean their wound with hydrogen peroxide, they're not showing good insight into what's going on with them. The AMSET is super important because psychiatry is one of those few professions where I can lock you away against your will, right? Anytime that you're trying to leave the hospital and medicine's super concerned, medicine doesn't do it. They don't lock you away. They call us, we come down and evaluate you, and we'll say, yep, they're not in it, they're not showing good insight, they're not oriented to person, place, and time, their affect is super flat, they're super manic now, like we need to go ahead and file an order of protective custody and detain that person, right? So that's where that AMSET comes in handy. That's your tool when you're saying like, hey, this guy needs to go inpatient, this person needs to be evacuated from country because they're suicidal, versus I can keep this guy, I can keep him, he's safe, he's just a little bit sad right now. That's your tool that you're using to inform that decision. Right? Again, rule out organic etiology first. There will be some test questions where I'm going to try and trick you. Make sure you don't get mixed up on that, okay? Trick's a bad word. I'm going to make sure that you understand the information. And then documentation, we're not really going to talk about documentation for psychiatric cases in this course. That's more going to be your junior year and your senior year. And then when you guys go on to phase 2, you'll be tired of documentation because that's what you're going to do for the rest of your life. But just realize there's a specific way that we will document this. Again, I'm not going to test you on this slide here. This is just more for example. Okay. Good. So that puts us right at 47 minutes. Any questions before we go on break? Going once, going twice, 3 times. All right, you guys are good. Go on 10-minute break. Yeah, sure. No.
The rat, yeah. It's I don't know the name.
No, we did not. Well, I'm not going to have.
Oh. I thought you were leaving. He's like, all right, where can you find the guy?
That's China.
Oh, you're talking about the yeah. I don't know, but it doesn't look like that. It's like
There's a car in there?
Dude, I watched some person in Nebraska. So you're watching Solo?
that's probably
I do. And most of the time I show it on like episodes. I'll sit there and study while I play. I know what's happening. They're all wrong.
Yep. Okay, yes.
So,
Okay, okay. It was only like 3 days. Yeah, like it went well. There's some questions Sasha could have answered better, so it wasn't that like. Yeah, like there's people on the last cycle who like they told him like a month before it started. Yeah, so it's like. Yeah. So it can be anywhere between now and March.
Wow.
It's because like it's high, but it's also like they don't get a lot of applications. segregation because like their main focus is like people in like 80-90% of their students are mind-based residents, and like so their class is only 55 people. There's only 15 people at the degree, and they only do like 3 rounds. They already did one in 10 days. They do another one in November. So the average grade is like 15 to 20 people. They're not saying
Mania is your CBO, your Belfort
so they have one. They've had one. What was new and recent, which was in the last like 3 to 4 years, was that now you get. So they've had the program, but it was only a bachelor's for like the longest time, like how I've had it. And then now they have, because if they don't, my baby isn't able to issue out graduate degrees, they partner with Nova so that you basically enroll in both. So while you're taking PA courses at Dave, there's a couple like online courses that you take for mix at Nova so that you can apply for a master's and then issue a master's so that you can mix and get sponsored. Yeah. Because Nova does have their own school sites, how UNMC, they have their own program. They still do. UM doesn't have one, if I remember. They have such a big medical program.
Your second
Yeah.
my brain. See about 4 down 6. It's the other brain. No. But this one, it's the only music one.
I've had a weird day. The game's one of the best in any I thought it really have one. Maybe it's when FIU has it, so they're like, we're more about it. But FIU is they're some newer, like they only got started like a year.
Oh my god.
FIU has like, they have some good stuff, and like, yeah, like, they're very hit or miss. Like, both my brothers and my sister graduated from FIU.
Absolutely not. But yeah. But that's all.
Majority of people I know.
That he is. That's why he has to go. It's so
like FIU, like they go to FIU is not expensive. Anyone especially if you're a data resident, like you're basically guaranteed FIU. Like it doesn't matter what. Like I applied there. Like when I came out of high school, I applied there. I applied to UF, I applied to Dave, FIU, and I was doing the math. FIU and Dave is the exact same semester, but Dave is easier. It's cheaper, and here's the thing for law is that if you earn a associate, you are automatically accepted to any state university. So let's say that with Dave and my associate, I'm automatically accepted to UF, FSU, I don't want to go to any state school I can. So it's easier, like, if there's a Dave. I did Dave on the
Yeah, I just go and I've always been like, every time I would go there, it was just people you weren't counting on leaders, professors you weren't trying to hear. The whole thing was like,
I did an AP. I didn't want to high school. I didn't try it.
I didn't have enough selling in so I had to get more credits if I did so like salary. Get like fun credits and high school. I hope she gets a call. Are you trying to do it
There's no base, the only base in Florida that has base 2, but You guys eat German and American, like, 2 hours away from Jacksonville, and but Edmond is like 9 or 10. Edmond is all the way up to Tallahassee. Homestead is not an active trade. That's an active trade. Might have to look into it. So like in the 90s, after Andrew got hit hard, they never fully repaired it, so they turned into a call base. So they don't have top. There's other shape on it.
Or sometimes they
It's not a big
they can't actually control it. They're just saying it because it has like some.
And then you have.
It doesn't have to be with anyone else. Okay. So that puts us right at 12 minutes. So we should be good. Okay, so this slide deck is a little bit smaller. We're going to talk about suicide specifically by itself. And really, what we're talking about with suicide is what I want you guys to really know from this deck is be able to identify the risk factors, right? What puts somebody at risk for suicide? Because that's really what we care about. If you guys work in healthcare long enough, you're going to have a patient that either commits suicide and completes or makes an attempt, right? Because they're struggling, something's going on. A lot of times they reach out to us and they're making that connection. Just a matter of time, you're going to be in the field if you work in medicine, you're going to encounter suicide, right? Suicide also, it affects us on the personal side. Most of us at some point in time in our life have either a roundabout way or a direct connection to suicide or somebody who commits suicide, right? It's something that's bad. It's a bad outcome. It's not a mental health diagnosis. I don't want you guys to think that, like, oh, you're suicidal, I'm going to diagnose you with that. It is a decision that they've made. It's the last minute resort, an outcome that comes from their disorder, okay? So again, those are your enabling learning objectives. That's straight from the syllabus. I'm not going to belabor that. This is kind of like just some general info. So again, 80% of patients had contact with their PCN within 1 year. I think that actually drops to about 40% is within the last 6 months. And this data is always kind of changing as they're doing those assessments, right? Psychiatric clinics, so again, that's like 25, 30%. Because again, most people have a mood disorder when they're coming to see us. That puts them at that higher risk. Next thing to know, there always is going to be this misconception that you guys are going to be able to screen out and identify who's going to commit suicide. That's not the case, right? We have screening tools, but they're only identifying risk. They're not going to clearly identify, yep, this person will commit suicide in this time frame. None of those tools exist right now, okay? I've had some patients who everything that could go wrong in their life went wrong, right? Like their kids died in a car accident. They got divorced from their wife. They got fired from their job, and now they were using alcohol. Like anything that could go wrong went wrong, and yet they just kept trucking along, never had suicidal thoughts. They just kind of pushed through, right? And I've had another connection where the person sold their hotel for like multi-million dollars, was ready to retire, was married in a good marriage, religious, had kids, had grandkids. Like you would think everything was going well in their life, and then they went and they hung themselves in the back shed using, I think it was weed whacker wire, right? Like it's extremes. We cannot predict who's actually going to commit suicide. All we can do is screen, and all we can do is ask. That's the best that we can do as of right now. Right? So, like I've already talked about, you're still going to screen them. You're still going to use like the PH29, the GAD7. You're going to use that Cincinnati suicide screener because we want something. We want to try and ask. And those can be used to help inform your decision. But you should never make that your final choice. Never let your screener inform your diagnosis. Right? That's just there to help you. Right? So, strongest risk factor for suicide. And this is non-modifiable. We can't ever change this. So it's kind of something that's good to know, but the utility of it is kind of benign. Like if you've tried to kill yourself in the past, there's a higher likelihood you're going to try and kill yourself in the future. When you're trying to predict what a patient's going to do, regardless of the specialty, right? Whatever has happened in the past, it's going to more than likely happen again in the future. Past predicts the future, right? So presence of a psychiatric illness. This makes sense. This is why our subspecialty exists, right? If you're having a mood disorder, there's a higher likelihood that you're going to try and take your life or be successful in taking your life. That's why it's such a serious thing. That's why we spend so much time documenting about this. So it's not just depression. Don't ever think, oh, depressed equals suicide. It's any sort of mood disorder and multiple different disorders. So if you're thinking like bipolar disorder, they're super at risk during the manic phase. So true mania, type 1 bipolar disorder, it only ends in one of three ways. It's either going to end with that patient being committed to the hospital, it's going to end with that patient being picked up by the police and booked into jail, or it's going to end in the death of the patient. Now, like mania is serious. So mania is bad, but also the flip side of mania, as we'll come to learn, is depression. And they're at risk again when they enter that depressive side, because now they're coming to consequences with all the actions they took while they were manic, right? People cheat on their wives when they're manic. People spend all their money when they're manic. People do drugs when they're manic. And then those decisions have consequences that they now have to deal with when they enter that depressive state, right? OCD is super debilitating to patients like obsessive compulsive disorder because, think about it, something is so significant in your life that you have to do a set number of rituals to get rid of that anxiety. It never truly goes away. That can be super debilitating, and sometimes you just want to end it, right? Because you don't want to deal with that anymore. When we talked about our schizophrenia, right? So akathisia, remember, you just can't sit still. It feels like ants are crawling up and down your bones. Imagine feeling like that every single day of your life until you come off of that bed. And if you come off that bed, you go right back to being a schizophrenic mess, right? Those higher risk of suicide in those patients just because of the drugs that we use. Right? So when you're talking about risk factors, living status, it kind of goes into similar order. So essentially, the best way to kind of think about this, the more alone you are in your life, the higher your risk of suicide is going to be. Having kids is protective. Being married is protective. Being part of your community is protective. We want to document that so when we release this person, we can show like, hey, no, they had a ton of protective factors in place. I think they're safe, right? Suicide is bimodal. So it tends to be the highest in our 18 to 24-year-olds because, again, you think about it, they're leaving the home. Some of them are alone for the first time. They have to start adulting, right? They have to adjust to society. And then again, when you're old, right? When you're old, all of a sudden people start dying, your friends start dying, you have significant health concerns. So now life starts to take the struggle bus again. It's bimodal. It tends to have those two splits. It's higher in males than it is in females as far as successful attempts go. Number of completions is higher in males. Number of attempts is higher in females, right? Reason for that, we think, is males, they tend to take a much more aggressive action because they don't really care how their body is found. Whereas with females, they tend to take a much less subtle action because they care about how their body is found. So males tends to be firearms hangings. Females tends to be like overdoses and suffocation, things like that, right? It's not perfect. That's how we think that breaks down, right? Military service. So being in the military doesn't necessarily raise your risk for suicide. Once you leave the military, that's where we start to see that increase in suicide, especially amongst our veteran population. And again, if you think about it, the military is a community, whether you guys like it or not. It's a community, it's a family. We force you to have friends, right? We give you friends. And all of a sudden you leave the military. Once you leave the military, they don't really care about you anymore. You're gone, you're separated. Now all of a sudden you struggle to make that connection. You struggle to make friends again because we're not giving them to you. Now you see those rates start to rise, right? There's also that combat plays a role, drug use plays a role, but you think the simple answer is you're leaving a community, now you're isolated and alone again. Those risks start to increase. There's more to it than that, but for right now, we'll kind of stop right there, okay? So genetic factors, again, I'm not going to, yes?
I noticed like 2 slides ago that you have, yeah, that one. I see that you have like dissociative disorders and personality disorders.
Mm-hmm.
I was wondering if like what your opinion was on DID, like is that separate from personality disorder or would you throw that under personality disorder?
It's a separate disorder. Yeah, that's one of the ones that's kind of, so we'll talk about it during those lectures, but personality disorder is different in that personality disorders, that is who you are, right? It's very difficult to change who you are, whereas one of the other disorders, in theory, with medication, with therapy, we can enact change and change your life and turn it around, right? If that's just how you are, it becomes much more difficult to treat. That's a very simplified view, but for right now, that should be good enough. Did that answer your question?
Yes, sir.
Yeah, we'll go through it. I think that's in block 2. All right. So genetic factors. I'm not going to test you on this. This is more just so you guys understand there is a genetic component when we're talking about mental health disorders. It does run in families. So I was just taking care of a patient just last week. The patient's father killed themselves by firearm while intoxicated. The patient's brother killed themselves by firearm while intoxicated. And now this patient was coming to see me, and they were seeing me for alcohol use disorder. And supposedly the wife states that he was suicidal while they were driving and he was intoxicated. Well, luckily, all the firearms were taken out of the house, right? So again, there's a very strong genetic component with that patient. There's a lot of other stuff going on, but it raises his risk level. Okay? When we're looking at this data, anytime we're doing big polls of data for mental health conditions, a lot of times it tends to come out of Europe. And the reason for that is they just have really good data sets because the moment you're born, they enter you into a registry, and that data is kind of tracked until you die. So a lot of times we get really good data from the Scandinavian countries just of how they pull the information, how their patients are tracked, right? So twin studies, again, this is just kind of for your guys' information. Twin studies are great because twins, because those who are monozygote, they have the exact same genetic profile, right? So that's about as perfect as we can get to like a randomized controlled trial in psychiatry, is talking about twins. And they've even shown that when one twin commits suicide, the other twin actually has an increased risk for that, right? Even if they're not even, if they don't even know each other, it's an adoption study. There's still that increased risk level. Genetics are non-modifiable. So again, it's something, that's why I'm not testing you guys on it. It's something to know and be aware of and talk with your patients. But ultimately, it's not going to inform our decision too much. It increases the risk, but we can't do anything about it. Right? Environmental influences. So childhood events are pretty significant, right? The more adverse childhood events that you have, it affects your development, it affects your milestones. It puts you at a greater increased risk in your adulthood, right? Traumas that we go through as adults, those play a part. Somebody who's going through a divorce, somebody whose kid just died, somebody who lost a pregnancy, again, that's at a higher risk. Roughly, so each one has its own number. I just kind of categorized it. You're talking about a 1.5 roughly increased risk to a 5% increased risk or 5-fold increased risk, just depending on the condition and what you're talking about and how severe that was to the patient. And you'll notice that there's no orange circle on this one. Environmental factors are important to know. It's where you need to get a good history from your patients, right? So, choice, this is just my kind of 2 cents. I was listening to a good podcast where they talked about this. The biggest thing I will tell you guys is when you're dealing with a patient who's actively suicidal and they have all these risk factors and you're talking with them about them, always reinforce to them like, hey, you have a choice. We can do something about this. What do you want to do about it? Always reinforce that that patient has a choice. You never want to give the appearance that like, oh yeah, sorry man, you're just going to kill yourself because of your family, your genetics, your environment, and your life cycle. Now all of a sudden you're reinforcing to that patient, oh, you're right, there's no way out of this but suicide. So you always want to offer that patient like, hey, we have a choice. What do we want to do about this? How do you want to approach this? Reinforce over and over again. The moment you tell somebody they don't have a choice, now all of a sudden it becomes that self-fulfilling prophecy where you're like, yeah, might as well do this. Captain Lane said I'm going to be an alcoholic because my dad was an alcoholic. Might as well just start chugging the handle. I'm like, okay, that's not true. That's not what I said. All right. Protective factors. So the exact opposite of being alone is you're in a community, you're involved, you know what's going on. It's not perfect, but again, you can kind of see that's a way we can inform our decision on who to release and what's going on with them. Pregnancy, believe it or not, is a protective factor. Being a parent is a protective factor. Being religious is a protective factor. If your religion states if you're going to kill yourself, you're going to burn in hell, and you believe that, you better believe I'm going to pull on that lever when I'm talking with that patient, right? I'm going to use that to give that person a choice to communicate with them and talk with them about what's going on, right? You always want to use these levers when you're doing your risk assessments, right? So subjective, that's your kind of, we talked about, that's just talking with the patient, getting your history. Your objective, that AMSEP, that's coming back, right? That's what you're gonna document to kind of say like, hey, this person needs to go inpatient versus patient can be discharged and go home. This person can be evacuated from country versus this person can stay. Because the moment somebody says like, oh, you know, I had some thoughts about killing myself, like you need to ask more and figure out what's going on with that, right? So I'll give you guys a good example of that. I had a patient, she was diagnosed with OCD, and every time I talked to her, she's like, yep, I have a plan to kill myself. I'm like, cool, how are you gonna kill yourself? I have a knife in the kitchen drawer, I'm gonna take it out, I'm gonna slash my wrists up, I'm gonna go to the bathroom, I'm gonna lock the door and sit in the bathtub. Very clear and concise plan, right? So, if this was the first time I was talking with her, you better believe I'd pick up the phone, I'd send her to the ER, we would get that person placed inpatient, right? However, this was the 7th or 8th time that I talked to her. This was always her plan. And this is over the course of about a year, right? She never acted on it because she had very strong protective factors. She's like, anytime I start to have those thoughts, I immediately call my husband. He comes home and he grabs me. We've taken all the knives out of the kitchen drawer and we got a lock on that, right? She's like, anytime I see the warning signs, so I start to get super anxious, my sleep drops to only about 3 or 4 hours a night, I start to overeat. She noticed all her warning signs, so we had a lot of protective factors in place. We were able to say like, hey, yes, you're at risk, but I think we don't need to commit you against your will on the inpatient floor. We can keep you in the outpatient, keep you in outpatient therapy, keep you with your family, right? Because we're able to use that subjective, the AMSET, to inform that decision, right? Good. There's always kind of like this I think it's kind of going away, the bias is starting to leave, but if you ask somebody, hey, are you gonna kill yourself? That does not increase the risk of them going off and doing it, right? A lot of times just being blunt, open, and honest with your patient, that's what they're looking for. They're coming to you for help. They just want somebody to ask, right? So another kind of recommendation is don't beat around the bush when you're talking about suicide. Just don't be like, so, how's life been? You seem super sad. Are you okay with being sad? You ever want to do something about being sad? Just straight up ask them, like, hey, you're going through a lot right now. Like, you're depressed, you're sad, you're going ready to go on deployment. Are you having thoughts about killing yourself? Yes or no? Do you have a plan on how you would kill yourself? Be open, honest, and ask them. Right? A viable plan. Asking if somebody has a plan is a very big thing. So the moment somebody tells you that they're having suicidal thoughts, your next step needs to be like, hey, do you have a plan on how you're going to do that, right? And then you want to figure out how concrete that plan is. So if your patient tells you, yeah, I'm having thoughts about killing myself, okay, how would you do it? Like, oh, I haven't really thought it through, but I might take my car and like swerve it off the road. Not a super concrete plan. The risk is higher, but it's kind of reassuring that they haven't taken those steps. It takes a lot more than to just drive your car off the road to kill yourself, right? But if they tell you, yeah, you know, I filed for, let's say their age of like 23, yeah, I completed my will, I'm gonna give everything to my friends, I started collecting up all my medications, I have them saved in a special drawer in my house, and then my plan is, I'm gonna go home, I'm gonna go lay down in bed, I'm gonna turn on some music in sync, and then I'm gonna take all my pills, right? Okay, that is a very clear, concise plan, and they've taken steps for it. They've now created a will, which 23-year-olds, they usually don't have wills, right? Like, that is a very concrete step that they've taken. That risk level should shoot through the roof on that person. That person should not be allowed to go home whatsoever, right? So, if your patient ever has a viable plan, do not release them, okay? Don't let them go. Put them on one-to-one watch. Start making the calls to get them sent to the hospital, okay? That is a big thing. If your patient is suicidal and they cannot keep themselves safe, you need to start getting people involved to get that person to the hospital. Do not let them leave, right? Do you take them to the ER? No, you do not. Do not put them in your car. You call the ambulance. Ambulance will come and take them to the ER, right? If you're deployed, situation's a little bit different. In that case, you're going to get their NCO, you're going to get a battle buddy, and you're going to put them in the car, so you basically have a 2-to-1, and you're going to drive them to wherever they need to go or fly them out wherever they need to go. That person's never left alone by themselves, right? And even when we take every opportunity and take every precaution, sometimes these patients, they will still kill themselves if they're super committed, right? There was a case probably about a year ago over at BAMC. Patient was on the inpatient floor, which that is a very locked down unit. They get put in pajamas. They don't even have strings. Patient was doing pretty good. They were getting ready to discharge him. I think the next day they thought he was pretty safe. He asked to go to the room to warm up his food, which if you're not on one-to-one, you're only on direct line of sight. They usually let you have a little bit more freedom, a little bit more movement, right? So he went to the room where all the food is stored. He opened up the microwave, took the plate in the microwave, smashed it, grabbed a shard of glass, shoved it into his neck, right? So then he killed himself with a shard of glass from the microwave tray. So even when we take our best steps, sometimes our patients, if they're truly committed, you're not going to interrupt that plan, right? But you always want to take every step possible to keep them safe, right? So that's where I say, don't leave the patient alone. That's where you take your medic, your battle buddy, somebody, put them in the room, they're on one-to-one watch with that patient, right? Remove harmful objects. So this is where it gets a little bit funky. Don't pat down your patient. That is what security is for. You always want to keep those boundaries between you as the provider and your patient. But you can ask them like, hey, I noticed you have a Leatherman on your belt. Can we go ahead and have that and put it in the patient's bag, right? Hey, I noticed that you have a knife in your pocket. Can we take that? Hey, can I take your pens from your ACU box? Can we put those away? Try and make that patient as safe as you can. Remove dangerous items from the room, right? A lot of times our med carts, we don't lock them up or secure them. Or they get broken over time. If there's like a ton of needles and scalpels in there, you need to take that stuff out, right? That shouldn't be in patient rooms anyways, but you want to make sure that patient is safe. Yep.
So that brings up the question of how closely related are SI and HI thoughts, right? Like, yeah, you're worried about the patient harming themselves, but the Leatherman could be used on you in order to be used on themselves.
So homicide is homicidal thoughts are a little bit different because it tends to be very, very targeted. A lot of times it's not at the medical provider, it can be, but if that's the case, a lot of times what they'll do is they leave, they come up with a plan, and then they'll come back and attack the hospital or staff, so it's a concern. What you're more worried about is them taking a sudden action in the room, and that's where, when you're in the room yourself, so I tell you guys, like, one, never want to block the exit, so that patient always needs to be able to see a clear line of sight how they can escape that room, and then two, you never want to have the patient block the exit on you, right? So don't ever position yourself where the patient's in front of you blocking the exit. Now that's your escape route. You can't get out of that room, right? It's just ways to keep yourself safe. If you're dealing with a psychiatric patient, making sure you don't have like your dog tags around your neck, making sure you don't have a necklace on, making sure your badge is breakable, right? Because otherwise they're going to grab you and assault you and try and take you down, right? If you're in a hospital setting, a lot of times what they'll do is that they'll call one-to-one and security will actually come down and sit and monitor them. If you're in a deployment setting, you just do the best you can. Have medics, preferably not your medics, you go to the unit and you ask them for one of their NCOs or a Joe to come and watch that person, right? You're doing the steps you can to make yourself safe. It's a risk factor, but believe it or not, usually if somebody's made it as far as the hospital and they're opening up to you that they are suicidal, it's actually kind of protective because they're asking for help. It's the ones who aren't asking that you have to worry about. It's the ones who are kind of like giving you not clear answers. Those are very vague. Those ones should be setting off red flags. Did I answer your question? Okay, cool. All right, detaining the patient. My strong recommendation to you all as providers, because you are going to be providers, do not physically detain your patient. That's not your role anymore, right? If you're deployed and something happens, get your medics to come in and help you, right? If you're in the hospital setting, that's security's job. Or there's nurses that are specially trained to detain patients. You want to have that step back so you can monitor the situation, so that you can order the medication, so you can communicate effectively with your team. Unless you absolutely have to, you should not be doing takedowns on your patients, okay? If they want to leave the room and they're super aggressive about it, I'm not going to stop them. I'm like, all right, man, you're good to go. And I'm immediately call security and they're going to track that person down. And they're going to make sure that they get them taken under emergency detention, taken to the ER to get evaluated, right? Right? Safety planning is a big deal. You want your patients to be able to safety plan, right? And there's plenty of forums and stuff out there to do that so you don't have to recreate the wheel every time. I love this app. I actually have this on my phone because a lot of times we're big phone people and we'll always have our phone on us, right? You may lose paperwork, you may lose pens. It's very rare that you lose your phone. They can actually download this straight to their phone and you can fill this out with them while they're sitting in that room. You want a safety plan with that patient before you let them leave, right? And then they'll always have that, okay? So safety planning is very, very good, very, very helpful. And it's a good way to kind of inform how much risk this person's at, right? So if I sit down with you and I go, hey, can you give me 3 friends that you can call when you're in crisis? And they give me 3 friends. Like, hey, give me 2 family members that you can call. All right, good. Tell me a place where you can go where you know you're going to be safe. How are you going to make your environment safe? If they're able to answer all of those, that's a good sign that this person's judgment is intact, their insight is good, and they're going to be able to keep themselves safe. If I ask them, hey, do you have 3 friends that you can call? And they go, I don't have any friends. Like, you might not have any friends, it's possible. Do you have any coworkers you can call? Everybody at work hates me. Again, now all of a sudden, that should raise your red flag. This guy is not thinking clearly. He can't even identify a single person to call. Hey, how are you going to keep your environment safe? You say you want to kill yourself with pills. How can you make yourself safe? I don't think I can keep myself safe. That should raise all sorts of red flags. If somebody's not able to safety plan, you shouldn't let them leave. Okay? Again, consult psychiatry, reach out to your friends. Your behavioral health officer is a great resource if you happen to have them. SSRIs, when you're making that choice, again, I know you guys have your farm test on Friday, so I'm not going to go too much into this right now, but that's why we like our SSRIs. They have a very good safety profile. That's why we hate TCAs, MAOIs. They don't have a good safety profile, right? Because what I want to do is, if that patient takes all their pills at once, are they going to be safe or are they not? Which they will do. Right? Monitor, close follow-up, kind of makes sense. You're now going to see these people a couple times. You're not just going to let them go free and wander off, right? Good. Again, ask, trust your gut. I think I belabored the points on this. All right, so this is kind of our final slide deck, so real quick. So acronyms, I'm usually not the biggest fan of acronyms. I never was able to really memorize them very much. They never really stuck with me. This acronym, I'll probably ask you 1 or 2 questions from like the suicide deck. So acronyms wise, probably not super high yield to memorize this, but as a clinician, this acronym I would argue is probably one of your most important ones, because when you're talking about who's at greatest risk for suicide, this is what we're going to use to identify that, right? It's called SAD persons with guns, right? So sex, males, again, males are more likely to complete, females are more likely to attempt, so you need to keep that in mind. Age, remember, it's bimodal, 18 to 24-year-olds over 75, right? Keep that in mind. Depression, so if they have a mood disorder, that's significantly higher risk. Prior history, so remember, what's been done in the past, higher likelihood that's going to happen again in the future. Ethanol is alcohol. You guys, hopefully you'll know that. Alcohol is a horrible drug. Now that I'm in the psych field, like now I kind of start to realize like alcohol is actually really, really, really bad. The only reason that alcohol is legal is because it's been with us since the dawn of time, right? If we cannot even get the world to legalize marijuana, which has a much safer profile, in today's modern age, if alcohol was invented 50 years ago, there is no way in heck that they would have legalized alcohol, right? It is a horrible drug. But yeah, alcohol, acute intoxication, you're at like a 7-fold increase of actually attempting and completing, right? Rational thinking loss. So this is where you start to think about like your schizophrenia, your deliriums, your intoxication. If you can't think clearly, you're going to be at a higher risk, right? Support system loss. So again, remember, if you are alone, you're at higher risk versus if you're involved with your community. Organized plan. If you're able to tell me clearly how you're going to kill yourself, that's a bad sign. You're at increased risk. Again, no significant other, bad sign, right? Sickness, yes. So this is the newest data. That slide is a little bit older. You guys can go with either one. So I didn't want to go into this too much right now. So we're actually seeing a dip in our suicide rates, and actually it's starting to affect our younger population, specifically like our middle school, the teenage years. We're actually starting to see a rise in that group, believe it or not. And we think that's related more towards the development of social media. I don't want to be that old fogey who's like, social media is bad. But social media for like a developing mind is probably not the best option. And we think that's what's causing our spike in suicides in kids, right? So this is a little bit newer of the data when I was pulling it, okay? Does that answer your question? Yeah, good. I'm not going to ask a question where it's like, you have a 14-and-a-half-year-old. What is the risk factor? Right? I'm going to make it a little bit more clear. I'll be like, hey, this patient is 25 years old or 23 years old, something along those lines. Like, or like, hey, it's an 80-year-old guy who's alone, right? Be a little bit more clear cut. Okay, cool. Support system loss versus no significant other. There is a nuance there, right? So again, if you're thinking like military-wise, they may be married, but they've just been discharged from service. They got their ETS orders. They're on their way out, right? So that's where their support system, the military, is gone, but they're still married. So they're at an increased risk. Now, if they're left the military and they also went through a nasty divorce and now they're alone, now you're hitting 2 blocks at a higher risk. So that's kind of where you're talking about the difference between those two. It's a nuance, but it is significant, right? Sickness. This is why when you're talking about MAID, so medical assistance in dying, this is why it's so contentious, is because I cannot tell you with 100% certainty that the grandma who has horrible cancer and they want to end their own life so they don't go through treatment, I cannot tell you with certainty whether that person wants to commit suicide and they're just using medicine as a way out versus they're completely rational, thinking it through, and they've come to this conclusion on their own, right? You cannot predict that because chronic illness definitely plays a part in suicide because illness sucks. We don't like to be that. And lastly, guns. This is because in the United States, 50% of our suicides are completed using a firearm, right? And this is kind of real quick. Cool. I'll hop on my soapbox. I think I'll be a bit on time. Firearms are bad, but I am a gun owner, and yes, this is the military. The military loves our guns, right? Be aware of that. However, there are ways you can talk with a patient about firearm and firearm safety without having to threaten to be like, the police are going to come to your house and remove all your firearms, right? You can bring it up to them like, hey, you're really kind of not safe right now. A lot of our suicides in the U.S. are completely using firearms. How can we make you safe? And some of the ways I've come across this is they'll say, hey, is it reasonable that we can take your safe, change the code, and give your wife the code, and she can hold on to it for now? And then once we're out of this crisis, we can convert your code back to the old one, right? So I just did my best to make them safe without taking away their guns, right? Hey, is it possible, if you don't want to do that, that's fine, you're worried about home safety, can we separate the ammunition? So now your firearms are in one safe and your ammo is now in a separate part of the house, or maybe your wife can take the ammo, right? Trying to make them as safe as I can, right? Is it reasonable that we can put weapon guards or trigger guards on all your firearms and your wife takes the keys, right? So you can try and make those persons safe without having to say, hey, we need to take away your guns and you'll never get them back, right? Because then that causes a very violent reaction in the U.S. population. And sometimes you kind of lose that therapeutic alliance with that patient because of that statement, okay? Another way I've done it is I'll be like, hey, is it possible that a family friend, we just take the guns out of your house, I don't want to know what you have. Is it possible that your family friend or your family member can take the guns and hold on to them for the next 3 or 4 months while you're safe, right? You're just trying to offer them a choice and a bridge to keep themselves safe with their firearms. And they're absolutely refusing everything. You're just going to document that. Be like, discuss all of these options with patient, inform them that most suicides in the U.S. are completed with firearms. Patient refused to remove firearms from home, right? In the military, it's a little bit different because we do have the ability to have MPs if they're in the barracks and stuff like that. There's different ways around it. And certain states do have red flag laws. What I'll tell you guys, if you're working on the civilian sector and you're worried about that, get the lawyers on the phone. That's what they're there for. They can give you an informed decision about red flag laws, what needs to be reported versus what doesn't as far as firearms. So, okay. All right, off my soapbox. Any questions about suicide? Yes?
Sir, what are your thoughts on the legalization of medically assisted suicide, and what is the data showing in countries where it is legal?
So that's a very political topic. That's a very personal topic for each individual. So there is no like clear-cut data. If you want to look into that, so MAID Canada has gone really big on MAID. And depending on how cynical you want to be, Canada's socialized medicine, getting sick is expensive, taking care of old people is expensive. You can get somebody to kill themselves, it saves you money in the long run. Again, very simple answer. But at the same time, patient choice is a big deal, right? Like, if that person, we don't want to just start infringing on them, taking away their rights. If they are of clear mind and it's legal in that country, and you have to, it's not easy. Like, you have to go through 2 different psychiatrists and medical, you have to get buy-in from everybody in order to do it. And if it's legal and you're of clear mind, who am I to say no, right? That's the kind of political answer. My personal answers are my own. If we want to talk about that, we can, but that's something that doesn't necessarily reflect the class. I don't want to cause harm.